All right, so this is the part 2 for Respi Rapid Review. Let me see if that's all right. Okay. All right, let's get started, Yashasvi. So,
Yes, sir.
okay, so in this session, we'll be talking about questions which are related to critical care and congenital and developmental anomalies. So, this is our first question. So, let's say we have a newborn who is at 38 weeks. He's having respiratory distress. On examination, there is cyanosis, tachypnea, and poor perfusion. Okay, poor perfusion means capillary refill time is not good of that baby. He is intubated and mechanically ventilated. Nasogastric tube is inserted. On examination, there is asymmetric air entry with decreased left-sided breath sounds. Okay, his abdomen is scaphoid. Chest X-ray is shown below. What do you think is the cause of respiratory distress in this patient? Cause of respiratory distress in this patient. What do you see in the X-ray here? What is this?
Air.
These are what? What
Air.
are these? Abdomen is scaphoid, so probably the abdominal content has protruded into the thorax. So there is one membrane here which is defective. Because of that defective membrane, all the abdominal contents are protruded into the thorax. What is that membrane here which is actually defective in this patient?
Hyaline membrane.
No. This is what? This is peritoneum, and this is what? The pleural cavity, right? This is pleural peritoneal membrane. If that's defective, all the abdominal content will be protruded into the thorax. And if that's protruded into the thorax, what is this kind of hernia? What is this kind of hernia called as?
Diaphragmatic hernia.
That's diaphragmatic hernia. Perfect. And this is diaphragmatic hernia, so the abdominal contents are protruded into the thorax. And because the abdominal contents are protruded into the thorax, what will happen to the lungs? Will they develop properly, or will they have pulmonary hypoplasia?
Pulmonary hypoplasia.
That's pulmonary hypoplasia. That's very perfect. So this is congenital diaphragmatic hernia because of pleuroperitoneal membrane defect. Because that's defective, all the abdominal content is protruded in the thoracic cavity. That's why you hear the bowel sounds in the thoracic cavity. The moment the question stem says that, okay, you are hearing bowel sounds in the thoracic cavity, it is congenital diaphragmatic hernia. Okay, and because it is physically occluding the lungs, you'll have pulmonary hypoplasia. Okay. Perfect. Let's go to the next questions. Like, you can stop me anytime if you have doubts. Okay. So let's go to the next one. This one. Now, this is a patient where the scientists are researching about new drugs. And in this pathology, there is some mutation which leads to abnormal protein folding and intracellular degradation. Now, we talked about two kinds of degradation. Just quickly remind me, if you want to digest any intracellular product, what do you need that? Like, how you can digest intracellular products? Or the other thing is, like, if we want to digest some extracellular materials, how will that be digested? Does anybody have any idea? How we should do that? If you want to digest intracellular products, there is something which is barrel shaped like this. So that intracellular product has to go through this barrel shaped organelle, and that will be just fragmented into smaller pieces. What is this barrel shaped organelle called as? What's that? Proteasome. So if you want to digest any intracellular organelles, you need proteasome for that. If you want to digest any extracellular organelles, you need to have lysosomes for that. Okay, this is a very important concept for any intracellular organ, for any intracellular things which you need to digest. You need proteasome. It will just ligate with the ubiquitin, that's called as ubiquitin ligation, and after that, that is sent to proteasome. And if you want to digest any extracellular material, you need lysosome for that. Okay, now there is one pathology where the patient might have recurrent respiratory tract infection, and that patient might be born with meconium ileus, and in that patient the scientists are researching about those drugs. In those patients, there is actually a problem with the folding of the protein. Because of that problem in the folding of the protein, there is misfolding of the protein, so that's actually undergoing intracellular digestion. Now what I mean to say, any protein which is misfolded inside our cell has to be digested. Otherwise, if it is not digested, it will just accumulate and cause more pathologies. So any misfolded intracellular protein has to be digested. That's one thing. This is what question is saying about this pathology. There is a problem, there is a pathology where there is abnormal protein folding that has to be digested by a proteasome. Okay, now there's a problem, like how would you, like if that protein is very essential, like for example in this pathology, you won't be able to do normal functions which this patient do. Like for example, this patient is having that misfolded protein that is actually digested, and actually we want that protein, so scientists are making a drug which can prevent misfolding and send that protein to the cell membrane, and the other drug improves the function of that protein. So this is a two drug therapy used for this pathology. Now after having said all those things, can you tell me that what pathology I was talking about? What is this pathology? Any idea about what pathology I was talking about? There is a misfolded protein. Cystic fibrosis, excellent. So this is cystic fibrosis, okay, where there is problem in the CFTR protein that is actually misfolded, and that misfolded CFTR protein is actually degraded by the proteasome, that's not sent to the cell membrane. Now, the scientists are making a drug in such a way that we have to prevent the misfolding of the protein. Okay, so there are two drugs therapy. One drug can prevent the misfolding and send it to the membrane, and other drug improves the function of that protein. Can you tell me the drug which can be used in cystic fibrosis? Drug which can be used in cystic fibrosis which can send the protein to the membrane? Very good. Very good, very good. So that's actually, we have two drugs. One is lumacaftor and one is ivacaftor. Okay, lumacaftor can send the protein to the cell membrane, and ivacaftor can improve the function of that protein. Okay, so what is happening actually, we have the CFTR channel, okay, that is actually mutated, and because of that mutation it is misfolded. Now that misfolded protein actually undergoes digestion. Okay, it actually undergoes digestion. Now what happens is, if we give lumacaftor, that protein will be that protein will not be misfolded, it will be sent to the cell membrane. Okay, let's say we have now the CFTR channel to the cell membrane. So that's done by lumacaftor. Lumacaftor prevents misfolding, send it to the cell membrane. Other one is ivacaftor, which can improve the function of this cell membrane. Okay, so this is lumacaftor and ivacaftor. All right, so that's cystic fibrosis. Let's talk about next one. So these are some of the features of cystic fibrosis. Just a second. Okay, so of course it is an autosomal recessive disease with delta F508. What do you mean by delta F508? What is delta F508? There is deletion of what amino acid? Deletion of phenylalanine. Okay, there is deletion of phenylalanine at 508 position. That's the meaning of cystic fibrosis, delta F508. And because of that, there is CFTR malfunction. We'll be talking about a lot of cystic fibrosis in this session. Okay, all right, let's keep moving. Okay, there is a young boy who comes with cough for the past 2 days that is productive of yellow sputum. Will you think about bacterial infection every time you see yellow sputum? Yes or no?
No.
Is it no? Very good. And why is the sputum yellow if it is not always bacterial infection? That's because of epithelial sloughing. Okay, this is your question. So why the sputum might be yellow? So yellow sputum, so any patient comes to you who is having yellow sputum, that does not necessarily mean that he is having bacterial infection. This can be epithelial sloughing as well. So don't start giving antibiotics to the patient who is having yellow sputum. But anyways, this young boy is having yellow sputum for that's like for 2 days, and he was also having history of bilateral pulmonary infiltrates. He was already having frequent episodes of pneumonia, and furthermore he had more episodes of pneumonia which required antibiotics for the improvement of the symptoms. Right now the chest x-ray is again showing bilateral lower lobe infiltrates. Further testing is showing high chloride content in his sweat. What's your diagnosis?
Cystic fibrosis.
Cystic fibrosis. Now you have to know about cystic fibrosis, a channel at two positions. One is sweat and another one is bronchi. Okay, let's say I am drawing sweat channel here. This is chloride channel, this is sodium channel, and this is your sweat pore. Let's say the sweat is going outside. In sweat duct you should reabsorb chloride or you should secrete chloride outside. In sweat duct you should like reabsorb the chloride or you should secrete the chloride.
Reabsorb.
Very good. You should reabsorb chloride, and when you reabsorb the chloride, it will also reabsorb sodium. Okay, so you should reabsorb sodium and chloride in the sweat duct. We don't want to lose electrolytes in the sweat. Okay, and if the CFTR channel is malfunctional, this channel will not work. You won't be able to reabsorb salt and you won't be able to reabsorb sodium and chloride. So sodium and chloride will be lost in sweat. That's why the mom will say my son is tasting salty. Okay, that's your buzzword. Okay, so this is the normal function of CFTR channel in the sweat ducts. What is the normal function of CFTR in the bronchi? Let's say this is your lumen of the bronchi, where you should secrete the chloride. Where is the direction of the chloride movement? You should secrete the chloride or you should reabsorb the chloride in the bronchi?
Secrete.
Very good. You should secrete. Let's say you are secreting the chloride. At the same time, what it will do to the sodium channels? Will it prevent sodium coming inside or sodium will come inside more?
Prevent.
It will prevent. Very good. Okay, so at the same, so this is the bronchi. Okay, chloride is secreted outside. At the same time it will inhibit the sodium channel so that the sodium will remain in the lumen. So we want sodium and chloride to remain in the lumen of the bronchi so that the water will also stay there, and that will chop off the mucus. Okay, that's why the mucus becomes thin. This is very, very important. If this is dysfunctional in cystic fibrosis, you start like retaining chloride inside and you will reabsorb more and more sodium inside. When you reabsorb more and more sodium inside, water will also come and your mucus in the bronchus will become very, very thick. And this can become thick anywhere. This can become thick in the pancreas. That's why you may have pancreatic blockage. This may become thick in the bronchus. So this can become thick anywhere. Okay, so this is cystic fibrosis CFTR mutation. You can use lumacaftor and ivacaftor again as we discussed. Okay, and there is of course improper folding of the transmembrane protein. Transmembrane protein, the protein that CFTR was, is actually a transmembrane protein. Okay, so if there is improper folding, that will be again degraded by which organelle in your cell? Which organelle will degrade that transmembrane protein if that's misfolded? Come on, which is this organelle where the misfolded protein are degraded?
Lungs.
Starting from P, proteasomes. Proteasomes will degrade the misfolded proteins. Okay, that's very important. All right, so that's because of improper folding of the transmembrane protein. You get those proteins degraded by proteasomes. Okay, 1 month newborn is having a lot of vomiting and he's having sleepiness. Newborn screening is positive for homozygous delta F508 mutation that's affecting the transmembrane protein. This is a screening test, guys. So when you do the screening test, you can do sweat chloride test. Okay. Otherwise, you can also do confirmatory test, which can exactly check for the mutation. Okay. But anyways, this patient is having, let's say you assume that, okay, this patient is having deletion of 508 and on examination is somnolent, he is having sunken fontanelle, dry mucous membrane. Which electrolyte abnormality would you expect in the baby of cystic fibrosis? Which electrolyte abnormality would you expect in patients of cystic fibrosis? Sodium. Excellent. That's sodium. So sodium is electrolyte abnormality is expected in patients of cystic fibrosis, and the reason why is this happening is because you lose sodium and chloride in your sweat, and when you lose sodium and chloride in your sweat, that's the reason you are having dehydration. Okay, this, why is this patient having sunken fontanelle and dry mucous membrane? Because you're losing sodium and chloride in the sweat. Okay, when you lose sodium and chloride in the sweat, of course you will get dehydration. Why this question has homozygous written in it? Why it is not heterozygous? Why cystic fibrosis mutation has to be homozygous? Why not heterozygous? Okay, what's the mode of inheritance, guys? Cystic fibrosis, come on. Mode of inheritance? Autosomal?
Recessive.
Autosomal recessive. If it's autosomal recessive, do you need both the chromosomes or both the genes to be knocked off, or only one gene to be knocked off? If it is recessive, you need like both to be knocked off or only one to be knocked off? If
Both.
it is both. Excellent. So you need both the genes to be deleted in order for the disease to be manifested, right? That's why it is written homozygous here. So both the genes are knocked off. That's why it is written homozygous mutation of delta 508. If it would have been written heterozygous and delta F48, this patient possibly might not have cystic fibrosis, because cystic fibrosis is an autosomal recessive disease, right? Okay. So we expect sodium electrolyte abnormality in this patient, so probably this patient will have hyponatremia. Okay, so that's your answer. Cystic fibrosis patient may develop hyponatremia. That's why salt supplementation is recommended in these patients. Okay, by the way, quick fact check: if the cystic fibrosis patient is getting recurrent pneumonia, and let's say he is getting recurrent pneumonia in less than 20 years of age, which is the most common organism which can cause pneumonia in patients of cystic fibrosis when the age is less than 20 years? Come on.
Strep pneumonia.
Staph aureus.
Staph aureus.
It is Staph aureus. Okay, the age less than 20 years, if you are having recurrent pneumonia, the most common organism in cystic fibrosis patient is Staph aureus. Which is the bug which can cause pneumonia in more than 20 years of age?
Pseudomonas aeruginosa.
Very good. That's Pseudomonas. Okay, so more than 20 years it's Pseudomonas, less than 20 years is Staph aureus. It's very, very important concept. Okay, so I think that's about the electrolyte abnormality. Next question. A man's pancreas is showing exocrine gland atrophy and fibrosis. He is having recurrent pulmonary infection and finger clubbing. There is the pancreatic duct, which are lined by the pancreatic duct should be lined by some other epithelium, but now that pancreatic duct are lined by squamous epithelium with keratinization. So this is actually squamous metaplasia of the pancreatic duct. If you want to maintain integrity of any epithelium in your body, let's say you want to maintain integrity of your skin, your conjunctiva, you should, like, let's say anything. If you want to maintain integrity of your any epithelium of your body, which substance or I would hint you, which vitamin do you need to maintain the integrity of that epithelium to prevent metaplasia?
A. Vitamin A.
Vitamin A. Very good. Okay. We need vitamin A to prevent metaplasia of any epithelium. Okay. There are four important functions of vitamin A. You have to hit this in your brain hard. Okay. Four important functions of vitamin A. Can anybody tell me before I tell four important functions of vitamin A?
Can tell one. Uh, First is you can have it's for vision.
Okay. Very good. You just have to remember you need vitamin A if you would just want to, party at night. Maybe just go to some clubs or something. But you need vitamin A for vision if you want to see that things at night. Otherwise, you need vitamin A if you maintain your epithelium. If you want your skin to be glowing, you need vitamin A. Otherwise, you need vitamin A for growth. Okay, of course, you must be 18 plus if you want to go to the club. And finally, your reproductive function should be intact if you are going there, right? So there are four important functions of vitamin A. One is vision, epithelium, growth, and reproduction. And they asked about epithelium, so you should know the functions of vitamin A. Apart from vision, it also has an important role in maintaining of epithelium. That's why do we have Bitot spots? What is Bitot spots, guys? What is Bitot spots? What is
Vitamin A
Bitot?
deficiency can cause Bitot spots.
Vitamin A deficiency can cause Bitot spots, but that's conjunctival squamous metaplasia. The reason why we have Bitot spots is because of congenital squamous metaplasia. Okay, that's a board question, that why do we have Bitot spots? That's actually a metaplasia of the squamous epithelium of the conjunctiva. Similarly, this is a squamous metaplasia. Why do you have Bitot spots? That's because of conjunctival squamous metaplasia. Okay, that's very important. Okay, now cystic fibrosis, if it is involving pancreas, it can cause all vitamin deficiency. Okay, we discussed this in biochemistry. If your pancreas is screwed up, you are going to have all the vitamin deficiency, be it vitamin A, D, E, K. So they can ask also patients who are having cystic fibrosis and come with bleeding tendency. Why?
Because of vitamin K.
K deficiency.
Very good, because of vitamin K deficiency. Okay, very good. Okay, a young girl is coming to ED due to 2 days of fever, productive cough, and shortness of breath. History of recurrent lung infection and cystic fibrosis. They have already given cystic fibrosis. Weight is 5th percentile. Why do you think there is failure to thrive, or weight are always on the lower percentile in patients of cystic fibrosis?
Because they can have vitamin A deficiency, and you just said that vitamin A is important for good growth.
That's one of the important thing. Okay, vitamin A. Otherwise, they'll have all kind of fat malabsorption because their pancreas is not functional. They won't be able to absorb fat. They won't be able to absorb nutrition. That's why they'll have always lower percentile of growth. Okay. Apart from that, why is this patient having hypoxia? Why SpO2 in cystic fibrosis patient is 86% here? Because of recurrent pulmonary infection. Okay, so because of recurrent pulmonary infection, they'll have hypoxia. Okay, on examination they have digital clubbing. Why do you think they'll have digital clubbing?
Hypoxia.
Very good. Because of hypoxia, you have digital clubbing. Okay, you are going to stimulate growth in your nail bed by releasing VEGF and platelet derived growth factors. Okay, all right. Now here the chest x-ray is showing hyperinflation, chronic interstitial changes, and infiltrate in the right lower lobe. Gram stain is showing gram-negative rods. Why this patient is having recurrent infection? Cause of this patient's recurrent infection. Why is this patient having recurrent infection? Because of, they have already said, like, they are having cystic fibrosis. Why this patient has recurrent infection? This is something related to microbiology, one property of bacteria where they love to be together. What is that property called as? Okay, I'll give you a hint. That property of the bacteria is actually wants to keep those bacteria together. That's a polysaccharide on the bacteria which keeps the bacteria together and prevents the drug to enter.
Lipopoly.
It is just poly. What's
Peptide.
that? No, that's a polysaccharide layer. That's a polysaccharide alginate layer from the group of the bacterias. What is that called as? If you form polysaccharide alginate capsule in group of bacterias, what is that called as? That is also in one of the bacteria which we saw, which was along with Saprophyticus. One bacteria along with Saprophyticus in that photo. What was that? Come on, that's biofilm. Okay. Pseudomonas loves to make biofilms. Pseudomonas loves to make biofilms by making polysaccharide alginate layer along with it. Okay. And when you make a biofilm, it's very hard for drugs to enter and destroy those group of colonies of the bacteria. Okay. So gram-negative bacteria like Pseudomonas, they can form biofilms, okay, and through that biofilm, that biofilms are very, very hard to break down, okay. So drugs have very hard time to break off those vicious cycle of infection. That's why these patients have persistent infection, okay. Now,
She's
we
young.
also,
She's
huh?
a young girl. She's a young girl, but why Pseudomonas? I mean, it's for adult.
Now see, if you that's a very good question, Yashasvi. So we talked about most common thing. If you look at the graph of bacterial infection in cystic fibrosis patient, this is what the graph of Staph aureus will look like. Okay, this is the threshold of 20 years. Okay, this is Staph aureus, Staph aureus, Staph aureus, Staph aureus, Staph aureus, Staph aureus. Okay, so most common organism is Staph aureus. But if you look about Pseudomonas becomes like this. After 20 years, its incidence increases. Now that doesn't mean in young age you cannot have Pseudomonas infection. Okay, is that clear, Yashasvi?
Yes, sir.
Okay, so in young patient, most common organism is no doubt Staph aureus, but you can definitely have Pseudomonas infection. All right. So biofilm is an important concept. So if they ask about what is biofilm, it's a polysaccharide layer. What is it made from? It's made from alginate. Why is it important? Because it can prevent the drug entry, and if once it prevents the drug entry, you'll not be able to break off that group of bacteria, and those patients will have recurrent.
Then they can have recurrent infection.
Perfect. Okay. All right. That's this next question. Okay, a 2-day-old boy. Okay, 2-day-old boy is coming with abdominal distension, palpable intestinal loops, and dark green emesis. The rectum has no stool. The rectal tone is normal. What we have ruled out in this patient? If I say the rectum has no stools and the rectal tone is normal, what I have ruled out in this patient? If the rectal tone is normal.
Hirschsprung.
Very good. Excellent. We have ruled out Hirschsprung disease if the rectal tone is normal. Okay. So the only other differential is actually the diagnosis of this patient. So which will come to no. Abdominal X-ray shows air fluid levels. Whenever there is air fluid levels, that means it is signifying intestinal obstruction. Contrast enema fails to relieve the obstruction. Now, when do we expect that the contrast enema should relieve the obstruction? In which disease pathology, which we learned in GI, we saw that when you give air enema or contrast enema, that will reduce the intestinal obstruction. What's your answer?
Meconium.
No. There is something which is telescoping something inside other. Okay.
Intussusception.
Intussusception. Okay, if you are having intussusception, the contrast enema or air enema can reduce that. Okay, of course you can have unsuccessful reduction there as well, but if you have intussusception, you can have failure to you can reduce that. That's an excellent answer. Okay, intussusception. You can have contrast or air enema to reduce that. Now, but here the thing is not even relieved with what do you call contrast or even air enema. So you do emergency laparotomy. Okay, anywhere if you like, if you are unsuccessful in reducing with the contrast enema or enema, your next step in management becomes emergency laparotomy. That's how you solve all the step 1 questions. Okay, whatever questions stems they are asking here, they will be the future questions for your step 2. So they wrote down some scenario, they wrote also the management. If that management failed, they also wrote the next management. These are all actually questions for step 2. But anyway, they did emergency laparotomy. They found out inspissated green fecal mass obstructing distal ileum. What's your diagnosis here? This is a giveaway. What is this green mass? Inspissated green mass.
Meconium.
That's Meconium ileus. That's very, very good. That's Meconium ileus. And why is it written inspissated? Why is it written inspissated? That's because it is dehydrated. Okay, because it's dehydrated, that's like kind of very, very sticky. That's why it is called as inspissated fecal mass. And why distal ileum? Because that's the narrowest part. Okay, so that's why Meconium ileus is like very common at the distal ileum, because ileum is very narrow part of the entire intestinal passage. Okay, now you have made a diagnosis of Meconium ileus. What's like very, very broad diagnosis? What is this boy having? Why this boy is having Meconium ileus? Because of
Cystic fibrosis.
Cystic
cystic
fibrosis.
fibrosis. Now they are asking what is the most common cause of mortality in this patient? That means what's the most common cause of mortality in cystic fibrosis patient? Your answer is
Meconium ileus.
no.
Oh.
It's not Meconium ileus. What's the most common cause of mortality in cystic fibrosis? Most common cause of death. Okay. Is it pulmonary? Is it cardiac? Is it intestinal? Is it kidneys? What?
Pulmonary.
It is pulmonary. Okay. They die because of pneumonias. Okay. That's the life-threatening thing for them. So the most common cause of death in cystic fibrosis is because of pneumonia. Why? Because they have recurrent infection. We already know why do they have recurrent infection, and we already know why do they have thick sputum. Okay. All right. So this is how you can differentiate Hirschsprung disease and Meconium ileus. We already did one thing about that, was the rectal tone. If your rectal tone is normal, you have ruled out Hirschsprung disease. If your rectal tone is high, then it's Hirschsprung disease. Okay. And Meconium ileus is common in cystic fibrosis. Hirschsprung disease is common in which chromosomal anomaly?
Down syndrome.
Down syndrome. Very good. Okay. Now you'll see squat sign in Hirschsprung disease as well. When you do the rectal examination, you see a lot of fecal matter coming out. So that's squat sign which you see in Hirschsprung disease. Okay. Next question. A 3-year-old boy is having productive cough and fever. He's tachypnic, ill-appearing, and there are rales over right lung. Chest X-ray is showing left lower lobe pneumonia. He's having frequent episodes of pneumonia already. His weight is 3%, so that means that already there is failure to thrive. By now you already know the diagnosis. So, but they also gave already the diagnosis that testing showed high sweat chloride content. There is a mutation in the transmembrane protein. So this is a giveaway for cystic fibrosis. What describes the dysfunctional transmembrane protein causing this patient's disease? Now you tell me that the protein which is here, okay, the protein that's the CFTR protein or the transmembrane protein of the chloride channel, what is it called? Is it a ligand bound channel, or is it ATP bound channel, or is it a channel which facilitates the transport, or is it a channel which is for passive transport?
ATP bound.
It is an ATP bound channel. It is not a mechanical channel. It is not a thermoreceptor. It is nothing. Okay, so that's ATP bound channel. Excellent. So we describe this as ATP bound channel. Okay, so that's ATP gated. That requires energy. Okay, so whether you want to secrete or whether you want to absorb chloride, you need energy for that, at least 2 molecules of ATP. Okay, a 6-year-old Caucasian boy. What are Caucasians? Whites, blacks, or Asians?
European.
Usually they are whites. Okay,
Yeah,
Caucasians.
whites, I mean. Sorry. Yeah.
Okay. So whenever they write Caucasians, it's whites. Whenever they write African American, it's blacks. Whenever they write Asians, you know that. So a 6-year-old Caucasian boys. Okay, he's having recurrent sinusitis and chronic cough. His sweat test is normal. Do you think the sweat test can be normal in cystic fibrosis patient?
Yes.
Yes. Okay. So sweat test can be normal in cystic fibrosis patient. So probably they tried to do the DNA testing, but that even was inconclusive. So now the physician ordered a further test which demonstrated the nasal transepithelial potential difference. Okay, now what you do, that you have your nasal cavity and you apply normal saline there and you check the transmembrane potential difference. Okay, potential difference between your the mucosa and your interstitial. You are measuring your potential difference. And if I say that, okay, while you apply normal saline and you are checking the transmembrane potential difference, and if I say that potential difference is becoming like more negative, why do you think the potential difference is becoming more negative in cystic fibrosis patients? What's your answer? Why do you think the transmembrane potential difference is becoming more negative in cystic fibrosis patient? Okay, I'm working on the nasal mucosa. Okay, I'm applying normal saline in the nasal mucosa. So normally in that nasal mucosa, what is the direction of chloride? Is the chloride secreted out or is the chloride absorbed back in?
It's
And then
absorbed back in. In the nasal mucosa.
Absorption.
Reabsorption, right? Reabsorption.
Yes.
so you are saying that in the sweat gland, so nasal mucosa will act like sweat gland, right?
No,
so,
no, sorry.
Sweat
No, sorry.
gland.
Nasal mucosa, it would be secrete, yeah. Secretion. Yeah.
Nasal
sorry.
mucosa is a part of respiratory tract, right? So nasal mucosa will secrete the chloride, okay, and it will. So this is the nasal mucosa which secretes the chloride, and at the same time it will inhibit the sodium, so that the sodium will remain in the nasal mucosa, and it will also remain. It will also make water inside the nasal mucosa. That's why, thank God, your nasal secretions are thin and not very thick like cystic fibrosis patient. If this patient is having cystic fibrosis, let's say we are in the nasal mucosa only, you won't be able to secrete chloride outside. And since you are not able to secrete chloride outside because your CFTR channel is gone, dysfunctional. At the same time, because of that, you won't be able to inhibit sodium channel. If you won't be inhibiting sodium channel, what do you think? Sodium will be absorbed more, or will it be remaining inside the lumen only? If you are having CFTR, it is going to be absorbed more. Very good. Okay, normally the sodium channel is inhibited, so sodium remains in the lumen. But if your CFTR is gone, you absorb more and more sodium. So relatively, what is your membrane potential becoming? If you absorb more positive charge inside, what is your membrane potential becoming?
Negative.
More negative. Okay, more negative. That's the reason why nasal transepithelial potential difference is negative in cystic fibrosis patient. Okay, that is what is written in the table, that the nasal transepithelial potential difference is negative in cystic fibrosis patients. So if you do sweat chloride test, that's inconclusive. If you do DNA test, that's inconclusive. The final test, if you are still suspecting that this patient is having cystic fibrosis, is you can do nasal transepithelial potential difference, and it will turn out that it is becoming more and more negative. Okay, all right, so perfect. Let's go to the next question. Let's start off with the critical care medicine. So that was all about congenital. Let's start off with the critical care. Let's say we have a boy who is born and who is like, let's say, planning to become like come to this world. And let's say before he comes to the world, you are trying to do amniotic fluid analysis. And this is what you find in the amniotic fluid analysis at the 40 weeks. At 40 weeks, you find some substance which are very, very high and at some substance which are very, very low. Can you tell me out of all this substance, which substance is very, very high at 40 week of gestation? Albumin, phosphatidylcholine, sphingomyelin, or phosphatidylglycerol?
Phosphatidylcholine is lecithin, right?
Yes. Phosphatidylcholine is lecithin, and
I am ruling out albumin and like option A and D. I think it's the middle two are the
E.
first or
B. Phosphatidylcholine.
okay. So actually, in reality, phosphatidylcholine is also called as lecithin. So phosphatidylcholine is also high, and actually phosphatidylglycerol is also high. Okay. So we have many answers that phosphatidylcholine is high. That is also high. Phosphatidylglycerol is also high, but phosphatidylcholine is equal to lecithin. So all these are high. And what is low? What's number 2?
sphingomyelin.
Sphingomyelin. Okay, so sphingomyelin is low, so that's why we do this ratio, which is lecithin by sphingomyelin ratio, and we want that the lecithin should be very, very high and sphingomyelin should be low. Okay, so if the lecithin by sphingomyelin ratio is high, that means the baby is ready to come out, or like still need more time? Need time. Or ready to come out. Okay, baby is ready to come out. Okay, how can you force your lungs to produce more lecithin or phosphatidylcholine? How can you force your lung to produce more phosphatidylcholine? Any drugs which you can give to the baby if the baby is premature, let's say 37 weeks? Steroids. Okay, dexamethasone is the drug of choice which can force, yes, that's correct, dexamethasone, which can force type 2 pneumocytes to produce more surfactant, and that surfactant is produced from which bodies of the type 2 pneumocytes? Which bodies actually release surfactant? Starting from lamellar bodies.
Yes.
Perfect. Okay, so lamellar bodies are the bodies which stores the surfactant in the type 2 pneumocytes, which secretes the surfactant. Okay, so if you give corticosteroids, that can stimulate your type 2 pneumocytes to produce more surfactant, and that is actually helpful to the baby. So any baby who is less than 37 weeks, give corticosteroids to them. Okay, very, very important. Insulin will inhibit surfactant production or will stimulate the surfactant production? Lot of insulin.
I think it will inhibit.
It is going to inhibit the surfactant production. That's why the mom who is having
diabetes,
gestational diabetes, mom has higher chance that their baby will suffer from respiratory distress syndrome. Okay, very good. Okay, next question. So these are all tests which you can do if you want to check the fetal lung maturity. Okay, you can do the lamellar body count, but you know that's tedious, right? You count the number of lamella inside the type 2 pneumocytes. But anyways, if you have very, very high lamellar body count, that's indicative of fetal lung maturity. Or you can do lecithin by sphingomyelin ratio. If it's high, the baby is ready to. Or you can check the phosphatidylglycerol. Okay, so phosphatidylcholine, phosphatidylglycerol, and lecithin, these all should be high. Okay, so even if it's phosphatidylglycerol which is high, that means the baby is ready. That's what I wanted to tell you. Okay, these are handwritings of Vishwa Patel. All right, next question. 23-year-old G2P1 with type 1 diabetes and hypothyroidism is coming to you with premature preterm rupture of membrane. That's PPROM. Okay, 30 weeks. She's taking all those things, vitamins and all those things. They are asking the same thing. The baby is like, what will you give to the gestational diabetes mom if she is at 30 weeks in order to prevent the negative outcome in the fetus?
Steroids.
Which steroids? Okay, corticosteroids. Okay, a bonus question for all those who are studying for step 1. You already know that the baby's age is less than 32 weeks. I will give one more additional drug to this mom to prevent dash. What is that drug and what are we trying to prevent?
Drug is steroid.
Steroid we are already giving. Steroid we are giving to prevent respiratory distress syndrome. I'm asking about other drug which we give when the baby is less than 32 weeks. That drug is dash that can prevent dash.
Magnesium sulfate.
Very good. Excellent. That's magnesium sulfate to prevent what?
Seizures.
To prevent
Cerebral palsy.
cerebral palsy. Very good. So magnesium sulfate is given to prevent cerebral palsy in the baby. Okay, no doubt magnesium sulfate is used in the treatment of eclampsia. But right now this mom is not having any seizures, but still we are giving magnesium sulfate to the mom in order to prevent cerebral palsy in the baby. Okay, so less than 32 weeks we need to give magnesium sulfate to the mom in order to prevent cerebral palsy in the baby. Okay, apart from that we also give steroids.
Sir, I have one basic question. This G2P1 means 2-time pregnancy and 1 child, right? How can we read this?
Yes. So G2 is 2 gravida. Gravida 2 means that female was that female conceived for 2 times. That means she was pregnant for 2 times, possibly 1 time underwent abortion, and right now, but she delivered only like 1 baby. So if any baby reaches the gestational age of more than 20, and if that baby is delivered, that's counted as para. If any baby who dies less than 20 years of age, that's called as abortion. Is it okay?
Yes.
So
sir.
this female got pregnant for the 2 time, but delivered only 1 baby. Possibly 1 baby just like got aborted. Okay. So let's go to the next question. So you now know that's dexamethasone. You give steroids to induce the lung maturity. Do you think vaginal delivery is more? Do you think what do you think is the risk factor for respiratory distress syndrome? Cesarean section or vaginal delivery?
Cesarean section.
The reason is like there is no physical squeeze, and yes, there is no stress hormones. Okay. There are no stress hormone because cortisol, steroids, we need steroids to induce type 2 pneumocytes, right? All right. Now, let's say this is the next question. A 1-hour boy at 29 weeks undergoes cesarean section. He is now having respiratory distress or respiratory failure. His SpO2 is 82%. He is having intercostal and subcostal retraction. He's having tachycardia, decreased breath sound bilaterally. You are intubating the patient, putting the surfactant, extubating the patient. This is called as INSURE approach. Intubate, put surfactant and extubate. Okay, surfactant and extubate. Intubate, put surfactant and extubate. That's called as INSURE approach. Let's say if somebody is having respiratory distress syndrome, this baby is already premature, right? So there are high chances that they will have the respiratory distress, but they are asking, after you give surfactant, what is going to happen to the lung compliance, functional residual capacity, and airway resistance? I'm asking after you give surfactant. They have asked prior to this clinical interventions. That means they have asked about before. Let's talk about both before and after. Before giving surfactant and after giving surfactant. Before giving surfactant, what is compliance of the lung?
Decreased.
If baby is
Increased.
compliance is less, after giving surfactant, compliance becomes
Increased.
Why? Because there is less. What happens to surface tension?
You get more surface tension, so that
You get less surface tension after you give surfactant.
Yes.
Okay, surfactant, the function of the surfactant is to decrease the surface tension. Okay, surface tension is initially high when you don't give surfactant, but surface tension becomes low when you give surfactant. Okay, apart from it, what is functional residual capacity before giving surfactant?
Increase.
Are the lungs small or are the lungs enlarged before surfactant? When you don't have surfactant, are the lungs squeezed down?
Small.
Small decrease.
The lungs are small. Okay, so what should be the functional residual capacity?
Decrease.
Decreased.
Less. Okay, so after giving surfactant, what should be the functional residual capacity? Lungs
Increased.
will enlarge.
They become
okay?
big. Yeah.
Perfect, because you are just popping off your alveoli. What becomes the airway resistance? Airway resistance before
More increased.
airway
is more-
resistance is yes, and after giving surfactant, the airway resistance decrease.
Yes.
Wonderful, perfect. Okay. So before giving surfactant, compliance is less. That means you need to work hard to change the volume of the lung. What's the formula of the compliance of the lung? Oh my God. What's the formula of compliance of the lung?
Pressure divided by volume.
Okay. Who said that? Yashasvi?
Yes, sir.
Pressure divided by volume. What is this?
So,
Resistance.
No. Compliance is delta V by delta P. It's VP. Okay, Vishwa Patel.
Okay.
Compliance is delta V by delta P. What is delta P by delta V? This is elastance. Okay, compliance is delta V by delta P. Delta P by delta V is elastance. Okay. All right. So compliance by definition is how much pressure you give and how much volume is changed. So when the lungs are full of fluid, you need to give more pressure in order to change even little volume. So this is a very nice graph which shows this is what is the initial total lung capacity of the baby. After you give like surfactant, the total lung capacity increase because the alveoli have started opening up. Okay, perfect. So let's go to the next question. A young boy is having a lot of welts, red color, patchy erythema everywhere. He's having difficulty swallowing. He's having facial swelling after let's say insect bite. Okay, after an insect bite, his blood pressure is falling down, heart rate is climbing high. He's having red plaques over the tongue, like trunks. He's having bilateral respiratory wheezes. What's happening?
Allergies.
That's allergic reaction. Which kind of hypersensitivity?
Type 1.
Type 1 hypersensitivity. Now they asked about molecular mechanism. Molecular mechanism. Okay.
Mast
Yes.
cells.
So very good. So you release preformed histamine from the mast cells. But the question was still different. When can you force those mast cells to release histamine vesicles outside? There is something on the cell surface of the mast cell. What is that? What are these things on the cell surface of the mast cells?
Antigens. Antibodies.
No! These are antibodies. Which antibodies?
Antibodies.
Which antibodies are there on the mast cells and basophils in patients having type 1 hypersensitivity? Which antibodies are known for allergies? That's IgE. Yes. That's IgE antibodies. And when the antigen comes, the antigen has to cross-link these IgE molecules. When they cross-link, well, that means they bind 2 or more antibodies. They cross-link, then and only then they will release histamine molecules outside. And first of all, you release histamine, that's preformed molecules, okay? You release preformed molecules of histamine outside, and then later, at the same time, you can give signals to the nucleus, and that nucleus can upregulate the production of leukotrienes with the help of increasing lipooxygenase, okay? So leukotrienes are also produced, but they are produced at a later stage because it requires signals from the nucleus. Okay, so you can form leukotrienes, but that's called as delayed phase reaction. If they ask about immediate phase reaction, that's histamine. Okay, that's a board question. So immediately you release histamine. After 24 hours, you may also release leukotrienes. Okay, that's a delayed phase reaction. Okay, so that's type 1 hypersensitivity. In order to release histamine, you need cross-linking. Spot diagnosis X-ray. X-ray spot diagnosis, ladies and gentlemen. What's happening? What is happening?
It's a clear lung.
Clear lung. Patient is having severe right-sided chest pain, shortness of breath after a fall, chest X-ray shown.
ARDS.
No. In ARDS, do you have like blackout lungs or whiteout lungs?
White.
In ARDS, the alveoli are filled of all the fluids. Okay, so lungs will appear all white. What is this? Severe pain. Oops, what's happening? It is pneumothorax. Yes, it is pneumothorax. Rajeshri and Vishwa, that's pneumothorax. That's perfect. Pneumothorax is the answer. That's blackout of the lung. Okay. Now this patient is having this patient is no doubt hemodynamically stable, but still you can have pneumothorax. Okay. There is no significant mediastinum shift in this patient. Okay, that's why probably this patient is hemodynamically like stable, but they are asking about physical finding. If that patient is having pneumothorax, see, first of all, Yashasvi, if entire you have to compare on the opposite side. You see the translucency here. It's not complete black. That means there is some bronchovascular marking. There are some alveoli here, but it is completely black. It's looking like clear. So this is pneumothorax. That means this is the border of lung. See, look how lung collapsed at like one place. These are all lung tissues have collapsed at one place. So this is all clear. So they are asking physical exam finding on the right side of the chest. So what will be the breath sound?
Decrease.
Decrease. What will be tactile vocal phrenitis? Tactile vocal phrenitis on the right side.
Increased.
TVF increased. Percussion.
Hyper-resonant.
Hyper-resonant. Very good. Tactile vocal phrenitis, percussion becomes hyper-resonant. Argadeep, tactile vocal phrenitis is decreased or like dull in consolidation. Oh no, guys, where is tactile vocal phrenitis decreased? Increased.
In consolidation.
Tactile vocal phrenitis, that means you are putting hands. Thank you for bringing that. When you are putting hands, you feel like more vibrations. So sounds is better traveled in which tissues, like solid, liquids, or gas? In solids. So tactile vocal phrenitis is decreased in pneumothorax. Tactile vocal phrenitis is only increased in one disease pathology, that is
Pneumonia.
Consolidation or pneumonia. Okay, very good. Consolidation or pneumonia is the only place where TVF is increased. Perfect. Okay, percussion is hyper-resonant here. So in consolidation, TVF is increased. In Pneumothorax TVF is decreased. Here percussion is hyper resonant. What is percussion in consolidation?
Dull.
Dull. Okay. If it is simple pneumothorax, I'm saying if it is simple pneumothorax, where is the mediastinum shift?
No shifting.
Either there is no shifting or either there is towards the side of lesion. Okay. In consolidation, if it's small consolidation, do we expect any shift?
No.
Perfect. No shift. All right. So that's your physical exam question. Do you think should you like insert chest tube in this patient?
No.
Why?
It's a pneumothorax, right? So
It is a simple looks like simple pneumothorax because there is no shift of midline. The patient is hemodynamically stable.
aspiration.
Huh?
Needle aspiration.
See, needle aspiration. See, fix this in your brain. You only do needle aspiration when it is emergency. So you only do needle aspiration when there is tension pneumothorax. In tension pneumothorax, the patient is hemodynamically unstable. Your next step in management is needle decompression. But if it is simple pneumothorax, and if simple pneumothorax is very, very small, then you don't need to do anything. But this simple pneumothorax is large. You look at the volume of the air. The lungs are literally collapsed. This is simple pneumothorax, no doubt, but this is large. So what's your next step in management? You don't do needle decompression. Okay, you don't do needle decompression. First, you directly insert chest tube. Okay. All right. Is it clear, Yashasvi?
Yes, sir.
Okay. All right. A middle-aged man is coming to you. He receives succinylcholine and propofol for surgery. Post-operatively, he is not recovering for the respiration. Post-operatively, he is not recovering for the respiration. His ventilator support is continued. Several hours later, the patient is successfully weaned from the ventilator. That means after giving succinylcholine and propofol, he does not recover spontaneously. We need his muscles are paralyzed, his respiration is not spontaneous. We had to continue this patient on ventilator. Why? Hint is, how is succinylcholine metabolized in your body? How is succinylcholine metabolized in your body? It goes to the plasma, and plasma does what? Plasma has something called as pseudocholine esterase. Okay, so that's perfect. Okay, we have pseudocholine esterase deficiency in this patient. That's why succinylcholine is not metabolized. That's why this patient is having prolonged paralysis. What kind of muscle relaxant is succinylcholine? Depolarizing muscle relaxant or non-depolarizing muscle relaxant?
Depolarizing.
It is depolarizing muscle relaxant. We'll study about train of force stimulation as well. So succinylcholine, see, this is your postsynaptic nicotinic channel. This is your postsynaptic nicotinic channel. Succinylcholine binds here and it allows little trickling of sodium. Okay, what will happen if it just allows little trickling of sodium? It's just like being in a relationship, but you are only allowed to do only little things. You become desensitized later on, right? So that's life. This is presynaptic terminal and this is postsynaptic terminal. When it is depolarizing neuromuscular blockade,
It does to the postsynaptic, right?
it does to the postsynaptic. Yes, it binds to the postsynaptic. It allows little trickling of the sodium, and a time will come that the postsynaptic membrane will become desensitized. Okay. The non-depolarizing blocker are very blunt. Okay, they don't do a lot, like they don't allow anything only. But depolarizing are like they allow something, but later on they become desensitized. So like non-depolarizing blockers are like tubercular or vacuronium. These are non-depolarizing. They just block, shut off, like no signals. But depolarizing are you can meet, but you don't do anything. So that's depolarizing. But anyways, depolarizing are metabolized in the plasma by pseudocholinesterase. See, we had acetylcholinesterase here, right? Acetylcholinesterase was metabolizing acetylcholine here. Similarly, we have pseudocholinesterase in the plasma, which metabolize succinylcholine. And if you have deficiency of that succinylcholine will be very happy, just like nobody's there to metabolize. It will keep on doing muscle relaxation, and you have like actually respiratory paralysis. I have seen patients who we had to keep them on ventilator for very long time. Okay, so it's also like very difficult to know this preoperatively that this patient is having pseudocholinesterase or no. Usually we don't check like pseudocholinesterase levels, but unfortunately these things can happen. All right, so that's pseudocholinesterase deficiency and succinylcholine. Okay, next question. A 20-year-old woman is coming to you. She is obtunded and responds only to the painful stimuli. The lungs are clear. Toxicology is positive for benzodiazepines. ABG is showing PaO2. Okay, you are asked the ABG finding. Okay, benzodiazepine toxicity. She is obtunded. What will be PaO2? What will be PaO2? Oh, what a silence. What will be PaO2, guys? What happens in benzodiazepines overdose? Are we still connected?
Respiratory alkalosis.
Okay. Respiratory alkalosis?
No.
What will benzodiazepines do to the respiratory rate?
Increase.
No.
It decreases.
Benzodiazepines will decrease the respiratory rate. What will opioids do to the respiratory rate?
It increases.
Oh my goodness. Opioids also decrease the respiratory rate. Benzodiazepines and opioids decrease the respiratory rate. That's why this patient is obtunded. Benzodiazepine, barbiturates, opioids, all of them decrease the respiratory rate. Okay, fix this in your brain. This is very important. Why would opioid increase the respiratory? The only drug which we want to remember in the poisoning, which can increase the respiratory rate, is like, think about what? Aspirin. Okay, aspirin can increase the respiratory rate and can cause respiratory alkalosis. But opioids and benzos and barbs, they decrease the respiratory rate. Please remember this. When somebody decreases your respiratory rate, what will happen to your PaO2? If your respiratory rates are low, will you oxygenate it properly?
No. Decrease.
No. Your PaO2 will decrease. If your respiratory rates are low, will you be able to wash out carbon dioxide?
No, so there would be increased.
PaCO2 will increase. Okay, so PaO2 decrease, PaCO2 increase. What will be the alveolar arterial gradient in benzodiazepine or opioid or barbiturate intoxication? Alveolar arterial.
Normal.
What? Normal?
Normal. Yeah.
It is going to be normal. Very good. Alveolar arterial gradient is going to be very normal because your membrane is intact. The problem is in respiratory rate. Okay, alveolar arterial gradient is only increased in the situations where there is problem in the membrane, like for example interstitial lung disease. Otherwise, alveolar arterial gradient, alveoli, amount of oxygen in the alveoli, how faithfully it is transferred to the arterial system. So alveolar arterial system is that diffusion is normal in a benzodiazepine overdose. Should we, like, do we have any antidotes for benzodiazepines?
Fluconazole.
No. Fluconazole is antifungal.
Fumaride.
It's flumazenil. Okay, that's flumazenil. That's an antidote for benzodiazepines. Do we have antidotes for barbiturates? Flumazenil. Do we have antidotes for barbiturates?
No.
No antidotes for barbiturates. That's why they are more lethal. Okay, they do not have ceiling. Okay, the more you give barbiturates, more respiratory depression they will have. We do not have antidotes for barbiturates. Antidote for opioids. Antidote for opioid?
Naltrexone.
No. It's naloxone.
Naloxone.
Okay. Naltrexone is used where?
Alcohol.
Naltrexone can be used to decrease the alcohol cravings. Okay, so you can use naltrexone there, but naloxone is an antidote for opioid. Just give it immediately. Okay, that can improve the respiratory rate immediately. But for flumazenil, it's not preferable for benzodiazepine overdose because if you suddenly block the benzodiazepine receptors in the patient, that can precipitate what? If you give suddenly flumazenil and block all the benzodiazepine receptor, that can precipitate what? Seizures. Seizures. Okay. It can precipitate seizures. That's why, see, benzodiazepine withdrawal itself can cause seizures. You block all the if the patient is like having intoxication of benzodiazepine and you are blocking all the benzodiazepine receptor at the same time, it can precipitate seizures. That's why this drug is only for theoretical purpose. Okay, in real life, we barely give benzodiazepines like flumazenil for benzodiazepine overdose. Okay.
So if the patient with benzodiazepine overdose comes, then what should be the first step in management?
First step in management is A, B, and C in any intoxication. You have to manage the airway, you have to manage the breathing, you have to manage the circulation. Okay. How will you manage? If the patient is not breathing at all, you have to like manage. If the patient is not breathing at all and patient is just comatose, what would you do? Let's say if the Glasgow coma scale of the patient is 7, what would you do?
Ventilation.
Intubate the patient and ventilation. Yes, you would stop all the drugs too. You would stop the drug sources, of course. Depending on what drug intoxication is, you can also do, and depending on when the patient came to you, you can also do lavage. Okay, gastric lavage. Anyways, okay. Tell me, if the ventilation is low here, if the ventilation is respiratory tract, respiratory rate is low here, what happens to P capital AO2 in this patient? I hope you know what is PiO2. That's like outside, that goes to your alveoli, that becomes P capital AO2, that diffuses to your artery and that becomes P small AO2. Okay, this is the inspired oxygen. What is PiO2? How much oxygen? It's around 150. By the time it reaches the alveoli, it becomes 100. Okay, and this can be, so actually it's like 104. By the time it goes to the arteries, it also like becomes 104 or around 100 if there is shunting. But tell me, what will be P capital AO2 in benzodiazepine overdose?
High.
Why? Why would it be? Your respiratory rate is decreased. Okay, you are like ventilating like less, so there'll be less oxygen in your alveoli, so your P capital AO2 will decrease. Okay, your P capital AO2 will decrease. As a result of that, your PaO2 is decreased. Okay. Do we change anything in PiO2?
No.
No. Okay. The atmospheric pressure, the atmospheric oxygen, it's remaining same. PiO2 is changed when you are at high altitude, but it's going to remain same when you are at the sea level. And if your respiratory rates are low, your P capital AO2 decreases. Okay. All right. So that's about benzodiazepine overdose. Perfect. This is what you have written, Vishwa. Reduced PiO2 at high altitudes, but that will remain normal when you are at sea level. Hypoventilation, that's like opioid overdose or CNS depression, all those things, AA gradient is still normal. So that's about benzodiazepine overdose. Okay, next question. 43-year-old man is having BP of this, pulse of this, patient is responsive to deep sternal lobe only, he is having dry mucous membrane, blah blah blah. This is their pH, this is their PaCO2, and this is their bicarb. How would you name this acid base problem? By just these values.
Respiratory.
Respiratory alkalosis with metabolic acidosis.
No. No. What is this? First of all, tell me, is it alkalosis or acidosis?
Acidosis.
It is acidosis. How do you know that's acidosis?
7.4 is normal.
Yes, so you have 7.35. 7.35 to 7.45 is the normal pH range, and if your pH is less than 7.35, we call it acidosis. Okay. Now this is acidosis. You know that that's acidosis. But PaCO2 is high or normal?
High.
This is high. So PaCO2 is high or like normal. This is of course high. So PaCO2 normal is 40. If it's more than 40, this is very high. So what about bicarb? Bicarb is normal or low or what?
Bicarb should be between 22 to 26, right?
Normal.
Yes, it is 22 to 26. I see some of the answers like decompensated metabolic acidosis, respiratory acidosis. So this is a tough topic. Seems like, okay, bicarb is normal here. Normal is 22 to 26. Bicarb is normal here. So you have not done anything with the bicarb till now. So PaCO2 is high, your pH is low, but your bicarb is normal now. Did we do any compensation yet?
No.
No compensation yet. Okay, so there is no compensation, that is for sure. There is no compensation because bicarb is still normal. Since PaCO2 is high and your pH is low, what kind of acid base problem is this one?
Respiratory.
Acidosis.
It is respiratory acidosis. This is not both respiratory and metabolic acidosis, Argdeep. If it would have been metabolic acidosis, your bicarb would be very, very low. This is respiratory acidosis at very, very beginning stage where the kidneys did not have time to compensate. Okay. All right. How much time does it take for kidneys to compensate?
2 days.
It's around like that's around more than 24 to 48 hours. So it takes like at least 1 to 2 days to compensate. Now, is it clear, Yashasvi, Vishwa and Rupika, this is respiratory acidosis without
Yes, sir.
compensation?
Yes, sir.
Would you ever call this alkalosis? pH is 7.18, Vishwa. This is like never alkalosis,
No,
like in
never.
any world. Okay. If your pH is less, your first step here is to, if you want to solve any acid-base problem, first look at the pH and label that. If this is acidosis, put acidosis here. Okay, and then check. Now let me tell you, if I say the pH is 7.18, bicarb is 16, and your PaCO2 is, let me say, that's 30. What do you think would you label this as?
Metabolic acidosis.
That is metabolic acidosis with
Respiratory
respiratory compensation. If you have metabolic acidosis, your bicarb is less, your pH is less, you know that's metabolic acidosis. Your lungs should do what? You should throw out acid or retain acid?
throughout acid.
Throw out acid. That's why your PaCO2 is like less. It's less than from 40. From 40 it became 10. So you are like hyperventilating now. So this is metabolic acidosis with respiratory compensation. Okay, is it okay?
Yes, sir.
Rupika, is this okay?
Yes.
This is very important. Okay. So this is acidosis, respiratory acidosis without metabolic compensation. Now kidneys like take a little time to compensate. So probably this patient might be having any benzos or opioids or any intoxication, and he's just coming immediately without kidney being compensated. Okay, perfect. So this is respiratory acidosis without metabolic compensation. Uncompensated respiratory acidosis. Okay, these are like various formulas which you like can know whether the compensation is proper or no, but we'll talk about that later. Okay, how would you label this ABG?
Acidotic, first of all, because
Okay, this is
pH is less
acidosis.
than 7.35.
Okay, then
Respiratory
okay.
acidosis.
This CO2 is less. Normal should be around 40.
Okay, Rupika, what did you say? Respiratory acidosis?
The compensation. It is.
You can.
Respiratory compensation.
Oh, okay. So you think this is metabolic acidosis with respiratory compensation? Is that correct?
Yes, maybe.
So this is acidosis, and you know you are hyperventilating. Yeah, but okay, now let's look at the history. A 34-year-old man is having respiratory failure because of opioid and alcohol intoxication. He vomited and had like hypoxia, shortness of breath had worsened. Things happened after vomiting. After vomiting, that patient is now having diffuse crackles. Chest X-ray shows bilateral alveolar opacities. What is happening? Chest X-ray showing bilateral alveolar opacity after vomiting, and patient was in like obtunded. What happened to the patient? And after that,
Obstruction.
Obstruction where? This is aspiration. This is aspiration. Okay. This is aspiration. Is it aspiration pneumonia or looks like aspiration pneumonitis?
Pneumonia.
Think and tell me. Is it aspiration pneumonia or is it aspiration pneumonitis? This is happening abruptly, quickly.
Pneumonitis.
This is pneumonitis. And how do you differentiate aspiration pneumonia and pneumonitis? Okay, what are you aspirating in aspiration pneumonitis? You are aspirating acid, gastric acid in aspiration pneumonitis. You aspirate your gastric acid in your like in your lungs, and your lungs will be damaged. Okay, and you get all those things very, very quickly. The patient can get ARDS from that. Aspiration pneumonia is you aspirate, let's say, sputum, which has a lot of bacteria, a lot of anaerobic bacteria, that can give you aspiration pneumonia, but that's more of an indolent course. It will take a long time. The patient will come with fevers and chills and foul smelling productive sputum. Do you think this is aspiration pneumonia?
No.
No. This is aspiration pneumonitis probably. Patient aspirated the gastric acid and he is now abruptly having all the manifestation of ARDS. That's why, probably because of ARDS, he's not having enough oxygenation and getting hypoxia. He's trying to breathe more, respiratory rate is increasing. That's why he's just also washing out the carbon dioxide. Okay. So this is aspiration pneumonitis, and because of that the patient has got ARDS. Okay, so patient has got ARDS because of aspiration pneumonitis, and when you aspirate your gastric acid, you are damaging your type 1 and type 2 pneumocytes. Because of that, your endothelial cells will be damaged. You increase your permeability, your lungs will be filled up of all the fluid, and you get pulmonary edema. Please tell me, what will be pulmonary capillary wedge pressure here?
Normal.
Thank you. Pulmonary capillary wedge pressure is very, very normal. Okay, it's absolutely correct. Okay, very good. Okay, spot diagnosis again. Spot diagnosis again.
Pneumothorax.
Pneumothorax, perfect. Okay, so they are just asking what will happen to the percussion.
But resonant.
Hyporesonant. Tactile vocal phragmitis.
Decreased.
Increased or decreased?
Decreased, sir. Decreased.
Low.
Decreased. Breath sound.
Decreased.
Decreased. Perfect. So that's very good. So this was happened after, they tried to do lung biopsy. That's why this happened. Okay. This is very good question. Very good question. Let's say you are having a woman who is having chest X-ray. Okay, she's having bilateral opacities. ABG is showing high alveolar arterial gradient. Okay. Now, what is happening actually? Look at this. When you are giving the patient oxygen just by oxygen, when you are giving patient oxygen by face mask, this is what the oxygen saturation is changing to. Initially on the room air, when the patient is breathing on the room air, her oxygen saturation is 75%. When you give 100% oxygen by face mask, her oxygen saturation becomes 78%. When you give oxygen and you increase the PEEP, positive end expiratory pressure, that oxygen rapidly increased from 78 to 96%. Of course, we are doing all these things when the patient is intubated. Okay, you intubated the patient and yet then you increase the PEEP. Why PEEP can increase the saturation here? When you increase the PEEP, what do you think will happen? No idea? You have your alveoli filled up with water. Okay, alveoli. They are all filled up with, let's say, fluid. Now, when your alveoli are filled up with fluid, they are just collapsed. Are they taking part in ventilation now?
You need greater surface area.
Your alveoli are filled up with fluid. Are they taking part in ventilation now? No. They are filled up with the fluid. Okay, how will the gas come and exchange? Okay, they are not as much as taking part in the ventilation. So the alveoli, because like it's filled up with the water, they are already collapsed, and whatever the thick content are there, it's just filled up with the fluid. Okay, so you just try to blow open the alveoli from outside. Okay, from this is, let's say, your like the airway, you are just blowing, trying to open up the alveoli. Okay, that's what you do with the PEEP. That's positive end expiration. While you are expiring, you are putting a positive pressure on the alveoli so that your alveoli don't collapse. That's called as PEEP, positive end expiratory pressure. You are trying to keep open the alveoli. When you keep open the alveoli, your ventilation will increase. Will your ventilation increase when you yes. Okay, your ventilation will increase.
I said that you need more surface area for ventilation.
Yes, you definitely need more surface area with ventilation, but if you want to increase the surface area, you need more PEEP so that it will open up, and once it opens up, you can participate in the gas exchange. Okay, now you tell me that when you are doing PEEP, are we increasing the dead space or are we decreasing the dead space? Or okay, let me reframe this. When you are giving PEEP, okay, let's say when you are not giving PEEP, your alveoli are just filled up with the fluid. Whatever blood comes directly goes from here to here. What is this phenomena called as? When you are having, let's say, ARDS, your blood is just passing from the right side to the left side without getting oxygenated. What is this phenomena called as?
Menger syndrome. No, sorry. Can you ask the question again? I'm sorry. I'll think.
When you are, I know what you are talking about. That's the same thing. When your alveoli are filled up with the fluid, your blood simply passes from the right side to the left side without participating in the gas exchange. This is called a shunt. Okay, this is called as shunt, when your alveoli don't participate in the gas exchange. Yes. So when you are giving PEEP from outside, what do you think, the shunt will decrease or increase?
Reversal of the shunt.
What do you think, the shunt will increase or decrease?
Decrease.
The shunt will decrease. Okay, very good. The shunt will decrease because when you are opening up the alveoli, now the alveoli will participate in the gas exchange. Once the alveoli participates in the gas exchange, this RBC, whatever are like coming from here, will get at least some oxygen. Okay, so it's just not directly passing from the right to the left side of the heart, it is getting oxygenated. So when you give PEEP, actually the shunt decreases. Is it clear to everyone?
Sir.
Okay. So when you give PEEP, your shunt decreases. The shunt decreases because it's not just directly going from here to there. Okay, so that's what PEEP is important.
Dead space, that would also increase, right? Dead space will also increase, right? If the PEEP increases.
What is dead space? Let's say you are having pulmonary embolism. That pulmonary embolism is just blocking one of the vessel, and there is no blood flow here. Q is 0, flow is 0, but still there is some ventilation, but this ventilation is not able to do anything to the blood vessels. You have enough of ventilation, but that ventilation is not taking part in the gas exchange. This is what is called as dead space. You find dead space in pulmonary embolism or when you block any of your vessel. When you are doing PEEP, you are opening up more alveoli. You are not anyway having problem with your vessels. It's not blocked. It's not blocked. So if at all it does something to the dead space, it might decrease the dead space, but it will not increase the dead space.
Thank you.
All right. This is a very good diagram signifying that there is no ventilation actually here. If there is no ventilation, but there is perfusion. If there is no ventilation, like for example, your lung is here filled up with all the fluid that cannot like bring ventilation. Your ventilation is 0, but perfusion is still 1. Your V or perfusion or flow, V by Q is going to be 0. Okay, this is called a shunt. This is normal. Flow is coming, ventilation is coming, and you are exchanging the air. This is dead space. That there is ventilation, but perfusion is 0. Okay. Now this graph is also like very important. As you know that if your ventilation is 0, like for example in ARDS your ventilation is 0. Okay, but flow is very good. So you know that your ratio should be near the 0. That's why this graph is near to 0. Okay, this graph VQ graph is near to the 0 in shunt effect. But in dead space ventilation, let's say you're having pulmonary embolism, your flow becomes 0, so your V by Q will become infinite. So it will be just towards infinite here. Okay, because of any, let's say, blockage in one of your vessels. That's very, very important. All right. Okay, this question. 87-year-old female is coming to you with like hypotension and she's having high WBC count. Apart from that, she is having low bicarb. Apart from that, she is having high lactic acidosis and she is having rhonchi over right mid-lung. Why is this patient having high anion gap? And if you look at the anion gap is 141 minus 104 minus 70. Okay, so that's how much? 141 minus 121, so that's around 20. Your anion gap is 20. That means it is high anion gap, and of course you know that the bicarb is less, so we call it high anion gap metabolic acidosis. Is it okay? Is this high anion gap metabolic acidosis?
Yes.
Yes. Why is this patient having high anion gap metabolic acidosis? She had some infection in the lung. Because of that pneumonia, now she is having high lactate and having high anion gap metabolic acidosis. Why? Very good. So this is lactic acidosis. Whenever you are taking care of a patient in ICU, if that you are suspecting that this patient can have sepsis, order ABG with lactate. This is what you want in the ABG. If your lactate is high, that means the patient is undergoing high anion gap metabolic acidosis. Very good.
This is mud piles, right?
Yes, yes. So apart from that, okay, this patient was having like severe infection, and after that severe infection, you started that patient on IV fluids and you gave them antibiotics. That patient improved fever, leukocytosis, and everything was improved. Now what is happening is rhonchi are still heard over the right lower lung, but now the chest X-rays, initially there was just pneumonia on one lobe. Now the chest X-ray is showing dense airspace opacity in the superior region of the right lower lobe. What's your diagnosis? What is your diagnosis if the chest X-ray is showing opacity in the superior region of the right lower lobe? What's your diagnosis?
Pneumonia.
What kind of pneumonia? This is aspiration now. Okay, this is aspiration pneumonia. So because the patient was lying down, now the patient aspirated, and these are the dependent portions of aspiration, right? Superior part of the lower lobe, lower part of the upper lobe. This is the dependent portion for the aspiration. So they are asking, what are the risk factors for aspiration pneumonia? So what are the risk factors? He had previous stroke. So because of previous stroke, his probably swallowing function were not okay. So because of that, he had aspiration pneumonia. Okay. So you have some swallowing dysfunction, you may have seizure, you may have altered consciousness, you can have severe vomiting. All those things can predispose you to aspiration pneumonia. Okay, that's very important. Okay. Again, spot diagnosis. What is this?
Air fluid level.
No.
Then pneumothorax.
This is pneumothorax. Okay, you have to see the how black it is. You have to know this. Okay, they will ask you, this is pneumothorax, this looks completely black. Now the thing is, patient was just watching TV, he was smoker, he was just watching TV and suddenly had pneumothorax. So they are asking, what is the predisposing factor? Why did this patient had spontaneous pneumothorax? What's your answer? Probably he may have some subpleural blebs. So that subpleural bleb might rupture. This is common in tall, thin, young patients where there is some connective tissue problem. So those blebs would rupture and you may get spontaneous pneumothorax, especially primary spontaneous pneumothorax.
So
Okay.
Smoking can't be a risk factor? Oh, but this...
Smoking is a risk, maybe a risk factor. And this patient is already thin and tall. And smoking would have aggravated that connective tissue defect, and they might have given subpleural blebs and that ruptured and they got primary spontaneous pneumothorax. Okay. All right, so this is subpleural blebs might predispose to this. Okay, now think and tell me, what is this? Old man is having even Marfan patient can have this. Old man is having shortness of breath for 3 weeks. He's having non-productive cough for several months. 9 kg weight loss, 50 pack per year smoking history. First of all, tell me, what is on the right side? What's your diagnosis on the right side? Think and tell me. Is it a cancer?
Yes.
Probably it can be cancer, but what we are looking for is something different. Cancer might be giving rise to this thing. Is it pneumothorax?
No, because pneumothorax would be more black. That's one thing I've
Okay.
learned.
Okay. What is this then? Why is it white? If air is black, then what is white?
Liquid. There must be some...
Distilled water there? Okay, what is this? Oh, this... Somebody has said there is paralysis of right hemidiaphragm.
Can you see paralysis on X-ray?
You can see paralysis on X-ray, but this is not paralysis of of right hemidiaphragm. If it would have been, I would tell you why is not this. But if I say that, it would just spoil the answer. Guys, when you look at the X-ray, what do you see first? What angles do you see?
Oh, the right
Costophrenic angles.
Yeah.
The right costophrenic angle is obliterated. So what do you expect when the costophrenic angle is obliterated?
Effusion, pulmonary.
This is pleural effusion. Okay. In diaphragmatic paralysis, your crostophrenic angle would be clear. Okay. So this is pleural effusion. Perfect. So this is pleural effusion.
Exit type of, because it might be a malignancy, that's why.
Yes. So this can be a malignancy. That malignancy is giving rise to like pleural effusion. Okay. Very, very likely. So they are asking now the physical exam finding of this. So you have to identify what is this first, and now you know like what will be the physical exam finding. What will be the breath sounds? Breath sounds?
Decrease,
Tactile vocal phrenitis?
Decreased.
Percussion?
dull,
Dull.
Dull. Okay, if this is large pleural effusion, where it will shift?
opposite,
Opposite. Very good. Next step in management? Next step in management? What are you going to do of this pleural effusion? Will you give diuretics to this patient?
Yes.
No.
Why?
You give diuretics when you are suspecting heart failure, and when you are suspecting heart failure, the patient will have bilateral pleural effusions. This patient is having unilateral pleural effusion. This patient is having weight loss, smoking history, probably malignancy. How would you manage this pleural effusion? First of all, you'll aspirate and send it for the cytology to rule out malignancy, right?
That's true.
The next step in management, you aspirate this pleural effusion, send it for the labs, and look what's in the pleural effusion. You have to divide that pleural effusion into transudate and exudate, and most likely, is this going to be transudate or exudate?
exudate,
This is going to be exudate. Okay, very good. What will be the protein content of this pleural fluid?
increase,
If it is exudate, proteins would be
increase,
more than 2.5. That's very good. It would be increased. What will be the pleural by serum protein? Pleural fluid protein by serum protein ratio. It should be it should be more than
0.5,
0.5. Very good. What should be the pleural LDH by serum LDH ratio?
decrease,
No. In exudate, a pleural LDH by serum LDH ratio should be more than 0.6, or your LDH should be just more than 200, or it should be more than 2/3 the upper limit of normal. Okay. What are these criteria called as?
Right criteria.
Lights criteria. If you just have one out of all these three things, what kind of pleural effusion is that called as? Exudate or transudate? If you just have one out of all these three things.
transudate,
No, even if you just have one, it is still exudate.
Exudate.
It is this or this or this, or even if you just have one, your answer is exudate. If you have all which are not meeting this criteria, all are less, then we call it transudate. Is it clear, Yashasvi? This is very, very important.
yes sir,
If you just have even one out of all these things, your answer is transudate. Exudate. But if you have all below, then it's transudate, and you need to aspirate that exudative fluid, because we want to rule out the infection, we want to rule out malignancy, because exudates, if you don't aspirate, has high chance of getting infected and you may get empyema. Okay. So this is pleural effusion, and of course you'll have less tactile vocal phrenitis. Okay, a diabetic patient is having fever, confusion, is having infected foot ulcer. You are taking you are inserting a central line, and there you are measuring from the venous blood, you are measuring the saturation of oxygen. In the venous blood, you are measuring the saturation of oxygen. The venous saturation of oxygen is 87%. Normally it should be 65 to 70%, but the mixed venous saturation of the blood is 87%. Is it high or low?
It's high.
High. In which condition the mixed venous oxygen saturation is high? In which condition the mixed venous oxygen saturation is high? Sepsis. Very good, Keval. That's sepsis. In sepsis is the only place where mixed venous oxygen saturation is high. This patient had foot ulcer, and because of that foot ulcer, now probably he is having lactic acidosis, and probably he is turning into sepsis. And you took the venous blood, your MVO2 is high, so he's having sepsis. So probably lactic acidosis, probably anaerobic metabolism is causing this. Okay. And of course you have like anaerobic metabolism, your mitochondrial oxidative phosphorylation is not happening, so that's giving rise to sepsis. What will be MVO2 in hemorrhagic shock?
Decrease.
Less. Very good. Okay, 12-year-old boy who like met with a drowning. Okay, he just like was drowned into the sea or any water bodies. Like he got ARDS after that. He was intubated, mechanically ventilated. He got okay. We discharged the patient, but after that he's still having mild dyspnea with the exertion. After drowning, you put the patient on ventilation. The patient got okay. You send them home. He's still having some dyspnea with exertion. So they are asking, what happened to this patient after ARDS and when you discharge the patient? For that, you have to know the stages of ARDS. What's one of the famous complication of ARDS which we can expect in patient?
Pulmonary hypertension.
You can get pulmonary hypertension indirectly, but first of all, one of the complication of ARDS is what? See, some patients will be fully resoluted. When you are having ARDS, first of all, you have endothelial cell injury, neutrophils will come, they will release cytokines, more things will happen, fluid will accumulate, finally macrophage will come, finally macrophage will call their friends. They will call their fibroblast friend and they lay down collagen. Okay, very good. So many of them have said like fibrosis. So this is fibrosis because see like from ARDS, one of the complication is fibrosis. Most of the patient might get okay. Most of the patient will get resolution of their symptom, but some patients still can get fibrosis. Okay, and this patient got actually fibrosis after ARDS. Okay. And what will be the AA gradient in this patient if they are getting fibrosis? AA gradient if they are getting fibrosis? High. Very good. Okay, if you are getting like if you are measuring AA gradient because of fibrosis, your AA gradient will be high. And now, Yashasvi, because of hypoxia, you can get pulmonary hypertension. Okay, because of pulmonary fibrosis. Okay, because of pulmonary fibrosis, what will be the compliance of the lungs now?
Decrease.
Decreased.
Okay, very good. And okay. So AA gradient will be high. Okay, a patient who died of respiratory distress. Patient who died of respiratory distress. Now you're taking lungs sample tissue, which are showing several large cuboidal cells, which has small lamellae-like body. So what this lamellae-like body are secreting what?
Surfactant.
Perfect. That's surfactant. So that's surfactant, and if you don't have surfactant, you have high surface tension, then you have high tendency to collapse. So lamellar bodies are produced from type 2 pneumocytes. Okay. A 60-year-old woman is having progressive shortness of breath and cough for 2 weeks. She had breast cancer. Okay. Examination showed inspiratory crackles over the right lung anteriorly. Okay, like listen to this very, very carefully. She had breast cancer and she underwent radiation after that. And after that, there are still some crackles on the right lung anteriorly. Otherwise, everything is okay. Chest radiograph is showing ground glass opacity on the right lung where the radiation was given. You had breast cancer, and after that, you do the radiation. After that, in the area of radiation, now you are having ground glass opacity. Why is this patient having ground glass opacity in the area of radiation? This is radiation induced what? Radiation
Lung
induced lung
injury.
radiation induced lung injury, which can give rise to radiation induced lung fibrosis. Okay. So this is a radiation induced lung injury or radiation induced lung fibrosis. So in acute phase, when you are giving radiation acutely, the patient might get alveolar edema. Okay, patient might get alveolar edema, but later on the fibroblast can come and lay down a lot of collagen. So this is radiation induced lung injury. Okay, old man is having shortness of breath, non-productive cough. Lung examination reveals decreased tactile vocal phragmitis over the lower right lung along with a dullness to percussion. What can be your differential diagnosis? If you are having less TVF along with dullness, can this be consolidation?
No.
No. Can this be pneumothorax?
No. In pneumothorax, you have hyperresonant.
Can this be pleural effusion?
Yes.
Yes. Can this be atelectasis?
Yes.
Yes. So this can be either pleural effusion or atelectasis. So depending on the option, you have to choose that. Okay. So probably the option was one of the pleural effusion. So that's why that's the correct answer. Okay. A hospitalized man had hypoxemia, worsening dyspnea. Okay, patient was admitted 2 days ago because of alcohol-induced acute pancreatitis. Whenever you hear pancreatitis and you have chest X-ray which are white out, what will you think?
ARDS.
Very good, ARDS. Now you are like, of course, in ARDS, that's a fingers crossed pathology. You intubate the patient. You are like planning to do mechanical ventilation, and you are putting some PEEP. PEEP is high, and again there is same question. If you are increasing PEEP, what it will do to the shunt? If you are increasing the
It will
PEEP,
decrease the shunt.
very good. It will decrease the shunt. Apart from that, if you are increasing the PEEP, it's just like the surfactant thing which we did. Okay, when you give surfactant, the total lung capacity will increase. Similarly, when you are increasing PEEP, the lungs will also expand, and when your lungs will expand, your functional residual capacity will also increase. Is it okay?
Yes, sir.
Okay. When you give PEEP, your lungs will also expand, your total lung capacity will increase, your tidal volume will try to increase a little bit, your functional residual capacity will also increase when you increase the PEEP. And this is pancreatitis induced ARDS. Okay. Would you increase the PEEP so much in patients having ARDS?
No.
No.
Why? What it will do? What it will do? Tell me, barotrauma. Right? When you increase PEEP so much, the alveoli will just rupture. You get barotrauma and might get pneumothorax because of that. Okay, because of very, very high pressure. So the preferred modality of ventilation when the patient is having ARDS is low tidal volume and PEEP in like sensible amount. Don't increase like PEEP so much. Earlier they used to increase PEEP so much in order to recruit the alveoli, but that's not a preferred thing now. Okay, what do you think here the problem is? Patient is unresponsive to anything. His PaO2 is this much and P capital AO2 is this much. Cause of this patient, like why is this happening? P capital A is this much and P small AO2 is this much. Why is this happening? I'll wait for your answer. This is very, very important. You have to think. Some of from like YouTube have already given the answer. What do you think, guys? Why is P capital AO2 less? Okay. Why do you think what is happening to the respiratory rate of the patient? Why do you think okay, first tell me what is normal capital PaO2? How much should be P capital AO2?
104.
Yes, around 104, right? Around 100 or 104. This patient is having less PaO2, so we definitely like know that this PaO2 is less. So similarly, what's normal PA small AO2? That's also around what? Around 104, 10, like 100, 100, right? So both PaO2 and PA, like both are decreased. Why?
Because respiratory rate is decreased.
Because the respiratory rate is decreased. Very good. Can you find the similar scenario at high altitudes?
Yes.
Yes, very good. Okay, because at high altitudes your PiO2, see here what is, if it's man is at the sea level, PiO2 will be normal. Okay, that's around 150. This is entirely normal. In this scenario, PiO2 will be still 150. Here PaO2 is 68 and P small AO2 is 60. That means there is some problem in breathing. The patient is not breathing properly. Let's say opioid or benzodiazepine intoxication or barbiturate intoxication. But at altitude, your PiO2 might decrease only. Let's say it is 100, then your PaO2 becomes let's say 68 and your PaO2 becomes 60. So this is at high altitude. This is at sea level, but the patient is hypoventilating and this is completely normal. Is it okay for everyone?
Yeah.
Is it okay? Okay. So this is alveolar hypoventilation. Okay, tell me, just by looking at the pleural fluid, the total protein is high. What do you think is the kind of pleural effusion? Exudate or transudate?
Exudative.
This is exudative. If you even just protein is more than 2.5, if any of all the lights criteria, if it's meeting that means we call that this pleural effusion is exudative.
It could be infection or malignancy, pleural malignancy.
It could be infection, it could be malignancy, and it could be because of because infection will increase the vascular permeability, so that will increase the protein content. That's why you have exudate there. Okay. 55-year-old man who is hospitalized with abdominal pain, labs is showing marked elevation of amylase and lipase. Epigastric pain with amylase and lipase elevation.
Pancreatitis.
What do you think? Very good. That's entry pancreatitis. The patient is already having high alcohol use. Now he is having crackles on bilateral side. What are you thinking? What is he developing?
ARDS.
This is ARDS. Okay. What do you think will you find in the autopsy? Like when you take a biopsy of one of the alveoli?
Highly in membrane.
Very good. So now you are expert in ARDS, I think. So that's hyaline membrane disease, which are also called as alveolar hyaline membrane. Anything which you see pink in histology is called as hyaline. Okay. Okay. Women is having dysuria, back pain, and she's now having fever, hypertension, and costovertebral angle tenderness. Skin is warm. She's having leukocytosis. Why is she having costovertebral angle tenderness?
Urinary tract infection.
Urinary tract infection. See, if it's just simple urinary tract infection, you won't get CVAT. If it is simple cystitis, you won't get CVATs. What is here? It's pyelonephritis, okay? It's pyelonephritis. If it's pyelonephritis, then and only then you will get costovertebral angle tenderness. That's why this patient is having fever and hypotension and all those things. That's why in septic shock, okay, I already told you the answer. This patient is developing pyelonephritis because of pyelonephritis getting the septic shock, and because of the septic shock, there'll be all vasodilation. That's why the skin is warm. Okay. Now, after septic shock, the patient is having now whiteout of the lung. What is your diagnosis? After sepsis, if the patient is having whiteout of the lung, what's your diagnosis? This is again ARDS, okay? So again, there is fluid accumulation in the lungs. Okay, this is your final question for the day. 45-year-old man is coming to ER. He is having severe dyspnea, chest discomfort. This is C. Okay, let me walk you through this. He's having dyspnea, chest discomfort, and he's having smoking history. Otherwise, everything is okay. What's important for us? The ABG shows PaO2 of 54 and PaCO2 of 26. After this patient is having dyspnea, chest discomfort, he's okay, respiratory rate is not given, but I am giving you, okay, respiratory rate is 30 and he's like having respiratory rate of, okay, that's respiratory rate is 30, and as a result of that, why is he having PaCO2 of 26?
PaCO2 is decreased, right?
Yes, why? Because of hyperventilation. Okay, when you hyperventilate,
Panic attack.
This is see, in panic attack, no doubt you get hyperventilation, but this patient is already having some trauma. No trauma. There is no trauma. There is no inciting trauma. But anyway, due to some pathology, he is having already dyspnea. Because of that difficulty breathing, he is already having hypoxia. So body's compensation would be to increase the respiratory rate, and when you increase the respiratory rate, your PaCO2 would decrease. Now, if you look at the graph, okay, I'll show you the graph in next slide. If you look at this graph, this is very important. This is as you increase the ventilation, high, okay, here, okay, as you increase the ventilation, your CO2 will decrease because you are washing out. As you decrease the ventilation, your CO2 will build up. Okay, this graph is very, very important, but you don't have significant change of oxygen concentration as far as the ventilation is concerned. This is normal. Even if you hyperventilate it, like, you might just increase your PO2 a little bit, but not so much, because your oxygen is already at max of its oxygen carrying capacity. Your RBCs are already carrying 4 pockets of oxygen. So even if you hyperventilate, that's not going to change your arterial oxygen concentration. But if you hyperventilate, that is going to significantly drop your carbon dioxide concentration. Okay. But if you hyperventilate a lot, then you might decrease your oxygen concentration. Is this graph like clear to everyone? Is it okay?
Yeah.
Yes, sir.
Drupika?
Yes.
Is this graph clear? Okay. Perfect. I think that's all for today. That's it. Had a very nice session. Okay, any doubts before we sign off?
No, thank you.
All right. Let's just stop the live stream as well.